Okay, good morning. Here, Nanjing First Hospital, this is the CAS Lab 2. We are very happy to invite Professor Mehta to be our moderator today. So, Professor Mehta, can I introduce my team?
Absolutely, would love to meet them. Please tell us who all you have in the room.
Okay, thank you. We are very happy to introduce our team today. On my right-hand side are my two mates, Professor Wu Xiangqi and Dr. Gan Jinxiang. And we also have the very sophisticated technician here, Dr. Pento, who you are very familiar. He's also the head of our technicians today. We also have two sophisticated nurses here, Nurse Shina and Nurse Jia Zihao. So this is our team. I'm very happy to work with you for today's live case. Next, I'd like to invite Dr. Wu Xiangqi to give you a case introduction today. Dr. Wu, please.
Good noon, honorary expert. It's my pleasure to show the patient information. Patient, 72 years old, female, chest tightness for 2 years, aggregate age for 3 days, risk factor essential hypertension. Lab test result is showed normal EGFR, high BNP, normal ECG, and the normal UCG. Left ventricular ejection fraction is 66%. We diagnose this patient is the unstable angina pectoris, current arteritis, essential hypertension. Next. The patient did the CAG 3 days ago. We see the LAO and the cranial position shows the proximal and the middle segment of the RCA is mild nasal lesion. Next.
No signal.
Next. We see the caudal position shows the distal left mid is the series nasal lesion. Occiput of the LED is the series nasal lesion, and the proximal of LCX is a series nasal lesion. We also see the proximal of the OM is series nasal lesion too. Next. Next, we showed the LAO and the IAO cranial position. Showed the LAD is series lesion, and we see the LAD, the lesion is very diffuse and distort. Next week, according to the CAG result, we see the left mid is the distal bifurcation lesion. According to Medilab classification, it's a type 111. Also, according to the definition criteria created by Xiaoliang Chen, a single bifurcation lesion. Next. Addition, we use the syntactic score to evaluate the patient risk stratification. We see the syntactic score is not very high, and the PCI and CAG is almost effect for this patient. According to the patient's viewing, we eventually the PCI to treat this patient. Next. Our strategy is according to definition criteria and ultimately try the result created by Xiaoliang Chen. We choose the PS technique to treat the patient and guidance errors. That's all. Thank you very much.
Thank you so much for the case. Here are my observations for the Medstream 360 global audience. So this is the second cath lab at Nanjing First Hospital. Today is week 8 of Medstream 360. I am Samir Mehta, the moderator, visiting here. An honor to do this from Miami. I'll continue to take all your questions. We'll try to make it interactive, use the experts here in the room to answer that. Just a straightforward observation, both rooms I noticed were Siemens. They've had decades of exceptional imaging equipment. The room is about twice the size of the previous room, and of course, the excellent team which we always watch on Medstream 360 is there. My pleasure being here. Left main bifurcation case, which to me, the most impressive part was this is a 72-year-old male, but minimal calcification, at least by angiography, which to everybody is a straightforward predictor how the outcome is going to be. Something like this, we can get absolutely pristine results. I'm also at the Mecca, the world's best center of DK crush. I'm sure that is going to be the approach that would be used, and we'll take you through the various steps. So with that, my initial introduction, I'm happy to put the case back to the operators. They'll take you through the discussions, and of course, in the meantime, we'll continue. In my previous case, I was talking about Medstream 360. People keep asking us, why was the program created? How was it done? Who are the people involved? How is it going to be expanded in China? And of course, globally. So just a pleasure being here. Let those questions come. And so what are your plans for this case?
Okay, thank you, Professor. First, I'd like to thank you to introduce our team to the worldwide. And as just like Dr. Wu have told us, the patient, I just want to supply some clinical message. The patient is only 150 centimeters high and low weight, less than 50 kilograms. So that's why today, I think you just want to see our today's angiography. Please, I will show you our today's angio. Because patient just performed the previous angio in the other hospital. So just because very complex anatomy of the distal left main bifurcation. So the patient just was transmitted to our hospital. Next, please. Next, please. Okay, it's the first view. No, next. Oh, previous view. Right. Okay. Because the patient from the PPT, you can know the patient is right dominant, only mild lesion in the middle part of the ICA. We just use the 7 French transfemoral approach, 7 French guiding cast EBU 3.5. And when we engage the guiding cast, we just find the BP dumping. So that's why I use the floating wire technique just to protect the ostium of the left main. You can see the 3 wires in the distal LAD, the distal circ, and also we can call the high takeoff diagonal or the Romer's intimate, because we just use the several oblique, we just cannot show very clearly the complex anatomy of the ostium of the.
So my other observation, which our audiences always comment on cases from China, and I've noticed that in CTOs, in bifurcation cases, that often just the number of wires which are used to provide support is a clear difference between how you approach your complex cases, which is highly educational, and I think that is one of the things which people can learn from global audiences. There are several questions I'm seeing here. All of them are basically directed at what is the approach you want to use for this lesion. So I'll let you answer that. What is your approach? What bifurcation technique do you want to use, and why?
Okay. First, I think why I choose the transfemoral. Usually in our center or in most the Chinese center, we use the transradial bridge, and it takes part more than 95%. But for this particular case, I just said the patient is short and very thin. So that's why I chose the transfemoral approach, because you can see very complex distal left bifurcation anatomy. We need more wire and also use the fighting wire to protect the 4 wires, 4 rounds of wires. So I think 7 French guiding cast I will use very smoothly to perform the whole case. And please show me the cranial. For this case, I think the most challenging part is just the big angle and the sharp lesion of the osteo-LAD. Next, please. And I can only show you that in this oblique, this projection, you can see the I mean the reverse angle of the LAD. For my routine performances, I like to choose the run-through wire because very high torqueable wire. If run-through fails, maybe I'd like to choose the more torqueable wire like the Xeon series. So I'm very happy, and I'm also very lucky. Just use the run-through wire with the particular shaping, just the two bands, and the first band 1 millimeter, the second band 3 millimeters, and with the more than 70 degrees bending. Next, please.
In this particular view, you could appreciate the very sharp origin of the LAD with the severe lesion right there. And probably it was in one of the RAO cranial views we had it, but we'll continue to. And then tell us what have you done so far? What is your thinking behind there? And again, going back to the previous conversation we were having in the room, quite a different approach here, using a femoral 7 French guide for all the reasons which are cited, and I agree.
Yeah.
So what have you done so far? And
you know, very complex distal bifurcation lesions. I think for this case, it's just a simple bifurcation according to Professor Chen's definition. So provisional standing is my first choice, but I need to know very clearly.
And of course, guided by IVUS, no?
Yeah, right.
Yes.
Because it has the 2A recommendations from the guidelines. But the very sharp lesion, severe stenosis of the ostium LAD. So just use the 2O balloon. Next, please. 2O balloon. Pre-dilate with just the nominal pressure. You can see the balloon expands well. Yeah.
Yes.
Next, please. And the flow also good. So next, I just check the IVUS for the both of the 3 vessels. It's LAD. So Dr. Pan, would you just give us the IVUS integrator? Thank you.
Okay, let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. We can see this point is the distal LAD, and the distal LAD vessel is normal. And here we can see the vessel diameter is not more than 2.0 millimeter. But the vessel, because the vessel is in muscle bridge. Then go and pull back, we can see the muscle bridge very long. And then go pull back near this side branch. Here, this is the second diagonal. Here we can see the eccentric plaque, and here is near the muscle bridge. And then pull back, we can see this vessel is normal near a big septal. So the distal narrowness is very short. And then here, this point can to do the distal landing rule. And here the vessel diameter is about 3.7 millimeter. Then go and pull back, we can see eccentric plaque. And here we can see the first diagonal we are drawing LAD. Then go and pull back. Here we can see the circumflex drawing LAD. This is the ostium LAD. The ostium LAD area is about 2.4 millimeter square, and the plaque burden is about 76%. Then go and pull back. This is the POC, and this is the distal left main. The distal left main area is about 5.3 millimeter square, and the plaque burden is about 69%. Then go and pull back. This is a body left main. The body left main vessel diameter is about 4.3 millimeter. Then go and pull back. This is a proximal left main. And then here, this is the ostium left main. The ostium left main is not normal. The area is about 5.8 millimeter square, and the plaque burden is more than 66%. We measure from the distal landing rule to ostium left main, the narrowness is about 23 millimeter. Okay, the second round we check out from the diagonal, first diagonal to LAD. And here we can see the diagonal vessel is normal. The vessel diameter is about 3.0. And then here, this point is the ostium of diagonal. The ostium diagonal is normal. The second round we check IVUS from the circumflex to left main. We can see the distal circumflex is normal. The vessel diameter is about 2.6 millimeter. Then go and pull back. The circumflex is normal. Here, this is the proximal circumflex, and we can see eccentric plaque near the ostium circumflex. And here, this point is ostium circumflex, the area is just 2.2 millimeter square, and the plaque burden is molten is about 75%. And the netness from the proximal circumflex to ostium circumflex is just 2 millimeter. Okay, this is the baseline IVUS imaging. Thank you.
Okay, thank you, Dr. Pan.
So nothing, were you surprised with the results of IVUS? Was there anything different which you would have expected by angiography? Again, clearly not much of a calcification. I could appreciate both angiography and by IVUS, but what are your thoughts and what are the plans going here? All the questions I'm reading so far are talking about bifurcation strategies.
Right. I think the key point for today's case, the bifurcation site. Just from the IVUS result, I insist on the provisional study. Even the IVUS measurement, we find that the lesion length of the side branch less than 10 is not the complex bifurcation one, just according to the definition criteria. And from the data from the EBC main, seeing a provisional standing also is our priority choice.
Okay.
So, Dr. Pan, how about the length is less than 22 or 20, 23. So distal reference diameter is 3.5.
Yeah.
Right. Left main is
4.3.
Okay.
So Professor Matt, I like to choose the a 3.5 stand and with the length 26. 26.
Sounds a good plan to start with. I think as we make progress, I'm sure that'll get modified. But completely agree with you. It's I'm sure this particular case compared to the hugely complex calcified bifurcation, trifurcation cases is relatively straightforward, but I'm sure some of the other questions which come in our mind, which you can take us through, would be how are such cases, are these cases considered these days so routine and simple that you do not even consider open heart surgery for them? I'm sure a few years before that used to be a totally different approach, but considering how successful and how well these cases do, so what is your approach? Was this kind of a patient provided a choice for open heart surgery and doing a bypass procedure, and do you have a heart team in place?
Okay, here just doing for because the patient the
pretty low Stent score.
Yeah, very low.
So there isn't much of a consideration here.
Yeah. Okay. So because I think from the IVUS result, we can see the very fiber plaque. And
Right.
Yeah. So I just use the cutting balloon 3.0, the warfarin, to prepare the lesion again. I think 2.0 is not enough big vessel. Go. Okay. It's the 3.0 warfarin.
Okay.
Inflate 6.
Okay. So
Sim
approach using cutting balloon here.
Okay. Yeah. Right. Okay. Okay. Done. Very focal lesion. So I just want to take a picture. Okay. Yeah. Okay. Seems good. Yeah. Because according to our experience, use the
How high did you go with the Wolverine there?
just use the 6 diameter 3.0 and the atmosphere with the nominal pressure.
Right.
Yeah. Because according to our center experience, use the cutting balloon, the modified balloon, we rarely got the plaque shift for the bifurcation lesions. So just as you see, fluid also good, right? Okay, give me the stand. Yeah. Please.
So there are some questions regarding obtaining best long-term results. Again, so much of that when you are stenting depends on having excellent stent apposition, verifying it with imaging. Often people are using more and more routine IVUS or OCT guidance. I can tell you that its biggest role in my mind appears to be to document the final result, and that is where I think comes its largest role, whether you need to do further balloon dilatations or take other steps for stent expansion. Beyond that, of course, our approaches of risk factor modification, role of course, statins, some of the other newer modalities, which we may get a chance to discuss with further.
So this the 30 by the length how 29 or 26. The Chinese domestic stand.
Okay.
Test please. I just want to cover the whole left mainstream. Okay.
And I think you have.
IO, yeah, IO. Routinely we use the IO cranial or airway cranial, the two objections to confirm our standard position.
Okay.
Okay, good.
Okay, test.
Okay, yes, test please. Thank you. So are you happy with this? Take a picture. Picture?
Okay.
Yeah, right. Picture. How do you think?
Maybe a little more distal, a millimeter or two, but it looks all right. It should cover very nicely.
Okay, you want to
yeah, I think
insert a bit more or?
Yeah, a little bit more, I thought.
Okay.
But
okay.
I think you're okay. You don't want to.
Test please.
Okay.
Let's take one more puff.
Okay.
Yeah, looks all right.
Looks right. Okay. Picture again. Okay.
Okay.
How about here? Because I was just an the oscillation of the left me.
Right.
I just want to 2 millimeters.
To be sure that is to come back a little bit.
Okay, come back.
Yeah.
Agree with you. Okay.
Yeah.
Test please.
Okay.
Yeah. Okay.
Maybe a little bit more now.
A bit more. Okay. Test please.
Okay.
That looks all right.
Okay. Go. Yeah. 6.
So by the
6,
standards of
6,
First
8,
Nanjing
6,
Hospital,
6,
I bet
8,
you this is
10.
one of their
10.
simplest
down.
left mains they have done in a long time.
Yeah.
And not to jinx any of these things, you require all sorts of care in selecting, and we'll take you through the approach of bifurcation
12.
stenting at
Okay.
Nanjing.
Okay. Let's take a picture to check the flow.
Okay.
Okay. Go. Seems good. Right. Okay.
Everything looks quite all right here.
Maybe I need
A little more spasm, I think, in the mid portion. Yeah. It's.
But before that, I just want to use the 1/Y balloon to post dilate the left main segment. Then. Yeah. Okay. Give me a 4O. 4O balloon. 4O. Chinese.
So over the last several years, I'm sure for all sorts of reasons, you're using more and more of the Chinese equipment.
Yeah, right.
So tell me more about which are some of the biggest Chinese companies. How
Microport?
Microport,
Yeah,
yes, we have heard a lot about it. Excellent company, a lot of a very expanded range of products. Are they also in structural heart?
Yeah, structural heart.
And
we have Chinese domestic valves. Yeah.
Yes, I have known about the venous valves, but
venous may be the first TEVA device.
Right. And what about Microport? Are they into structural heart also? And
right.
Is this Dr.
16,
Chen's
15.
short balloon?
Okay.
Yes, Professor Chen's short balloon.
Okay.
Yeah,
The
just designed for
pot
the
balloon, huh?
Yeah, you're right. With the
16.
no shoulder. When the 16.
Okay.
Okay. Done. And with the lens 6, it's very suitable for the port.
I can tell you any visit to China is always
16.
20.
amazing in all sorts of discovery. At the hotel, I traveled here in a incredible the electric car. I think it's BYD is the company. Tons and tons of
BYD company.
Yeah.
Have you tried to drive their cars?
Yeah, I traveled in their car this morning, and it was very, very impressive. Very impressive.
So build your dream.
Yes.
Okay, take a picture, please.
Okay.
Give some nitro, because
there's a lot of spasm there. I think that would be a good idea. So
yeah, right.
So do you already have in China a separate fellowship for structural heart, or as part of interventional cardiology it is covered?
Yeah, right. We have. Okay. And a very mature team.
Dedicated for structural heart.
Yeah, right.
1 year or 2 years?
I think for structure, first, you are very sophisticated with the other interventional skills.
Right.
Like very familiar with the coronary artery intervention,
Sure.
PCIs.
Sure.
Yeah. Sometimes when you need to protect the coronary artery, so without the PCI technicals,
You cannot get into.
yeah,
You're
right.
absolutely
yeah, I agree
right.
with you.
Completely.
Give me the right caudal, IO caudal, please. We just check the ostium of the two side branches. Okay, take a picture again.
Going to examine if there has been any plaque shift. Not, I mean,
Yeah,
the flow is very good, a slight shift, but excellent flow. I don't think
yeah.
that should make you modify your strategy.
On the screen, you can answer.
Yes, yes, I answered all of those.
Okay, move to
They're all dealing with the bifurcation technique.
Give me 35 hyperballoon 365I just want to post dilate the LED segment stent. Okay. 右头，把那个忘了。回放上一张 previous view please. Previous view, IO view. Yeah.
So what would your, as we continue to expand Medstream 360, what is the educational needs of the Chinese interventional cardiologists, the fellows who are training, what kind of cases, we are trying to broaden our range of cases. Again, we are realizing that more and more cases, of course, not unsurprisingly, are being done
10, 12, 12.
structural cases, but
So, Professor, I have a question for this case.
Uh-huh.
As you can see, just from the cranial view and the caudal view, seems like two side branches not compromised. Will you always perform the kissing or just leave it open? Because if we check the QFR or FFR, I do believe that two side branches have the more than 0.8.
right.
So do you always perform the kissing?
Not always,
Not
not
always.
always, not always. And
Any skills for this technique?
no, I think if you can have reliable FFR guidance, that always helps. I think to have a rigid strategy of having a mandatory kissing balloon is not necessarily the case, and often, as I think it may turn out to be in this case also, you may decide to leave it alone.
Okay, Jude,
But,
that's small, right?
Yeah,
Okay.
but we'll see. And so far, the flow is good.
I will show you the
Questions coming up that within the IVUS space, are there more some emerging patterns of use? My question to you is, are the Chinese companies making imaging equipment, and how good are they?
Okay, I will show you the I have the result just
Just
after
a
the
mild calcification, that's
Yeah.
all, at 11 o'clock.
I just use the 3.5 hyperballoon and
Right.
post dilate with the 16 millimeter,
Right,
nearly
right.
the rupture pressure.
We can see
Yeah,
the
you-
distal stent edge have a medial dissection.
That section, yeah.
Yeah.
Seems like the distal part. Here, stent expands very well.
Yeah, stent diameter is about 4.0.
Oh. Okay.
Yeah.
And we cover the ostium, right?
Yeah.
Okay.
So all the questions have been answered. Keep having those.
Further, you here medial dissection.
Dissection.
Dissection is
About the medium? Involved
Two-
the medium?
2 millimeter.
2 millimeters.
Yeah.
So also satisfied with the ultimate criteria, right?
So
Okay, take a picture again. Okay.
Yes, that was not angiographically apparent, and
Go. There's no. Oops, sorry.
Insert your.
There's no. Yes. Okay.
Okay. Okay. Okay. I have to. Okay. Okay.
The getting us. Go.
Okay. It's very clear.
yeah, a lot of overlapping there. You don't really appreciate much of that. I think going with the IVUS is the.
I just insert a bit more.
Uh-huh.
Okay. I was again.
Okay. I use NTG again.
No.
Yeah.
NTG.
I think I was this one is more distal.
More distal. Okay.
Yeah.
Agree with you. Thank you.
And this one, the minimal stent area is about 8.1.
8.1. Okay.
Yeah.
Bigger than before.
So, how much is your annual coronary PCI volume at the center?
Is this center?
Uh-huh.
For this year, I think nearly 66,000. Yeah, 6,000.
PCI.
Yeah, last year,
It's
over
number one in
4,000.
Jiangsu province.
Yeah, just
So,
in our center.
so that would be what number in the country? Number 3, 4, 5, 6? Where?
Maybe in the top 10.
Top 10.
Yeah.
That's what I thought. Very good. And Fuwai Hospital still continues to be the leader in Beijing.
Yeah, right.
Good, very good. But look, this is a very impressive volume. And how many senior academic operators?
Here we nearly have the over 8.
Excellent. Very good.
Because we have the 7 groups, nearly 8 groups.
So at the end of the year, an interventional fellow in training would do how many PCI cases under training? About
Here you see the every
yes?
fellow.
Uh-huh.
According to our training courses, every fellow should finish nearly 100 PCIs. But it's just the type A or B, not including some complex.
That looks too small. 100. You mean 100 or?
Because, yeah, I mean just independent PCIs.
Operator. Okay. Yeah. Are you also having some fellows who are training from outside the country? They come
every
here
year
every year.
Have, yeah.
Very good. Very good. Because with this kind of an expertise and volume, I think your center can provide so much training to students from elsewhere.
Our
okay.
leaders just to pay more attention for the younger, the junior doctors.
I think that is needed.
Okay, Doctor, I will stop here.
Okay, stop.
Just please, maybe
okay, let's do the
IVUS
run.
Yeah, the IVUS.
From the distal stent edge to normal. 13.
13.
Yeah.
Okay, also 3.5, right?
3.0.
3.0
is better.
Stand.
Yeah.
So Professor Matter, Dr.
and
just
14. 3.0 and 14.
Suggest us to add one stand for the distal part, just because the edge dissections
is continuing. Yeah, absolutely.
Yeah. Although the lens is
and probably you're looking at a 3.0, no?
Okay, 3.0. Yeah.
Yes.
Lens.
Okay. So as I walked through the walls of your cath lab, looks like you've had 2 great interventional cardiologists who have guided your development, Dr. Spencer King and Dr. Greg Stone.
Yeah, right. Yeah.
Very impressive. I speak to Dr. Stone all the time, and he mentions about so much work you have collaborated on, including numerous research protocols.
Just because of for the past 3 years, because of the coronavirus inclusion, every year, before 2019, every year we invite Greg Stone and Professor Spencer B. King, our case lab.
Absolutely. 2 giants in the field of interventional cardiologists, and they have contributed so much, and I'm not at all surprised to see their influence, and I'm sure that has guided you to create a more academic program.
13.
13.
30.
13 is not enough.
3.30, no?
Not enough.
3.30.
Yeah, 3.30.
13.
The 2 professors do help us a lot in the past few years, just like you have done here now.
Right.
Thank you very much. Okay, sounds good.
So this is that
just nearby the
middle segment, which
yes, please.
Okay.
Yes, please.
Okay.
Okay, maybe a bit more, right?
Yeah,
okay.
Okay.
Take the picture, please.
Okay.
Picture.
Okay. Wait a moment. Okay.
Okay, ready.
Okay.
Okay, take picture. So, Professor, I think here is good, right? Just
yeah, looks all right. Yeah.
Okay.
Right.
Go.
Okay.
Go.
Go.
Go is up to 6,
Six.
6,
Okay.
8,
8.
8,
And the
10.
question is, could
10.
you even have used a
Okay.
longer one to have covered the entire mid portion also? But let's see how it looks. And once again,
10.
Going up 10, 12.
12.
Okay, done.
a
Okay.
lack
Okay,
of calcification in a bifurcation lesion is, I think, the single biggest factor which makes it easier to expand stent and have a long-term better outcomes. Are there any first-in-man work you have done at your hospital?
Sorry, first man for
First-in-man devices you have used at your hospital?
first man, maybe Chinese domestic.
Okay.
Yeah.
What about some techniques like the pulmonary artery denervation
Yeah,
that
right.
has been
Yeah,
pioneered
right.
here?
Yeah, right. 308个 H 呢 I use the 30 NC balloon to post dilate the segment. Okay.
So let those questions come. Happy to answer that. Thank you for making it interactive. Once again, should the viewers have missed my previous case moderation from the other room, I'll give you a little summary about what's happening with the Medstream 360. Acknowledge some of the work which has been done in China. If you notice here, we've got two exceptional video streaming technologies. One which is based out of Montreal, BroadMed View with Danny Trottier. This one by Dr. Yang's company, MedUnion, both exceptional. The program is today running in its this is second center amongst our 12 centers that contribute on creating a 24-hour uninterrupted live cases. I can tell you some other updated numbers which the viewers may be interested to know. This should be case number 144 in the journey with Medstream 360. Pretty early experience, but if you can figure out on an average, we are having 20 cases a day during these live transmission. 51% of the cases are still coronary, comprising the largest two groups are left main bifurcation, trifurcations, and CTOs, and about 44% structural heart, with the TAVR and mitral clip being the more common procedures. We've been picking up very large numbers of tricuspid cases, a lot of adult congenital heart work coming out of centers such as the Madras Medical Mission out of India, with a lot of pulmonary lesions, a lot of AST closures, a great case of sinus venosum, a lot of patent ductus arteriosus, even the whole depth of structural work continues to increase. The way this functions is we almost track down the solar movement starting from the east in Asia, expanding through to Europe and the United States, with the intent being wherever you are, this is interventional cardiology on demand. Go on your mobile phone, either on the Medstream website for dedicated viewing, or on YouTube. You're able to watch experts demonstrate to you interventional cardiology live and on demand from these top centers around the world. So far, things are looking good. You're happy with the stent expansion there. I think that coverage was pretty good. What do you plan to do now?
I think just according to your recommendations, we don't need to perform the kissing, just because the from angiography, the two side branches seems good, flow is good.
And confirmed by IVUS.
Yeah. You want to see the IVUS?
Well, I think it would be a good idea. Should and we have a few more minutes. I think that would be good to continue with that too.
Okay.
And in the meantime, you go ahead and image that, and I will continue to educate the people. I'm seeing we have 14 more minutes. There are so many. I truly welcome this opportunity to be amongst all of you at First Hospital in Nanjing. This is week 8. Today is also dedicated TAVR sessions where we'll be doing numerous TAVR cases from around the world. The intent being to demonstrate to you how this very broadening category is being approached globally. What are some of the novel techniques? What is the overall trend? Some new devices with it, and we conducted a similar exercise during week. I think it was week 6 or 7 when we did an entire IVL day. That there were 13 IVL cases from around the world. The intent is to use the MedStream platform to often pick up emerging technology, emerging product. We deliberately targeted IVL and demonstrated some exceptional use. The beauty of MedStream 360 is the same technology is used in different methods in different countries. Those decisions are often guided clinically, often guided by economic reasons. And it is our hope that such a aggregated experience will help you make better decisions. The entire intent is to make better outcomes for patients and to use a global platform to advance interventional cardiology techniques. Want to thank the MedStream directors who have been helping me along over the last 3 years of this remarkable journey. Dr. Michael Gibson, Dr. Greg Stone, Dr. Samin Sharma, Dr. Ron Waxman, Dr. Paul Tierstein. Should any of you be listening, thank you so much for your contributions. It's a challenging journey, a very disruptive technology, the one which clearly provides what I believe in my heart is a complement to exceptional educational work which happens at the TCT meetings, at Euro PCR. The format here is different. If you would have noticed, we are at ease. Nobody's rushed here. We give a total dedicated 1 hour. You can take longer if the case goes long. We firmly believe at MedStream 360 that when you're doing a complex case for the betterment of the patient, for a very global, very complete educational experience, to have the time not forcing you to make these difficult decisions. I encourage the operators, they always discuss that they should discuss the case plans. Interventional cardiology, no case in my estimate in the 35 or 36 years I have done it. I think it rarely goes as per plan. I think the nice thing is to continue modifying these days. So many of our procedures are image guided. They are guided by physiology to continue changing it so that the experience is richer. So at MedStream 360, at least I have never, not even once, asked any of our exceptional operators to rush with the procedure. Sometimes the procedure goes long. We move to the other site and the case is recorded and put on the website. A second very important part of the cases which I'm sure observers they keep commenting on it often. Most of the comments are extremely complimentary. I'm happy to listen to even some matters of any concerns or recommendations that you have. But so far, people like the approach that, look, if you have got true experts, excessive moderation is not needed, as you would have noticed in this case. There are two amazing, many things we continue to learn at Medstream 360. There are things you can only model that much. Then you start a program and now you've got a true feedback. There are cases being done, and in my mind, I have noticed that there are two levels of styles of moderation which are emerging. If you watch cases which are being done out of Montreal Heart Institute, often through La Paz University with Dr. Alfonso Jurado, and definitely with the Madras Medical Center with Dr. Shivakumar and Dr. Ajit Mulaseri. It's a very collegiate, friendly, calm, unrushed discussion about the case plans, the recommendations, the changing. There is something else you will find extremely useful at Medstream 360, which I urge you to do. Each week, amongst the almost 20 cases which are done, the fellows at Lumen Foundation, where they do the video editing, they basically kind of vote to select which was the most educational of the live cases, and this emerges out to be what we call as the case of the week. And so far, this is session number 8. There have been 7 cases of the week, all exceptionally teaching cases. And I'd like you to focus on this aspect where I'm mentioning to you about the need or the lack of or there being a strategy which we have used at Medstream 360 to avoid excessive moderation. And I cite to you all the case which was performed by Dr. Hung, and I think it's Dr. Robert at Montreal Heart Institute. This was the case of the week from last week, where they had a highly complex dissected and compromised left main, and in a most unrushed collaborative fashion, the management of this lesion was performed. I don't think that is a coincidence. I think these kind of things are probably because of the format which we have very carefully thought through with Medstream 360, that once you have true world experts, you don't want them to be having excessive guidance. I mean, I mean, if Dr. Sharma at Mount Sinai is doing a complex left main bifurcating case and is having challenges with the rotational ablation, I don't think another expertise is needed to guide him. Often all what is needed is unrushed environment, a calm aspect, and that is what I think the live case at Medstream 360 provided us. Many of you have asked me what are our plans for Medstream 360, how are we planning to take it forward. All those are excellent questions. I personally do not know the answers to all of them. I can tell you is that we have been hugely encouraged by the results of the pilot. The program was so innovative, so new, that there were aspects which we were uncertain of. How do you really do 24 hours of uninterrupted viewing? This is session number 8, and we have not had any interruptions so far, and we continue to learn. Our intent, of course, would be to expand the one day into twice a week and maybe then take it forward. That is one of the reasons I find myself in mainland China. There are several sites which have expressed interest in participating. I would like Medstream 360 to be a mainstream. It should be a part of some kind of a collaboration with the medical societies. In the meantime, let me take you back to the case. The bifurcation is looking good. The circumflex ostium looks to be good. The flow in the LAD is excellent. I think that diagonal or that ramus there, it may be just the view. I think where it is showing that at the origin of it, it's probably the high diagonal or something, a little plaque shifting, but the flow is excellent. We'll probably view it across in another view. You have any comments to make about your case in the meantime? Let your questions come. We are about 6 minutes still we have in the session, which I will take you through the motions of the plans for Medstream 360. There is also a little announcement which we put there that should your site be keen for participating, we are happy to take those interests. So the intent would be that, look, based on the early response, which of course I must also tell that what about the mid portion of the LAD? You think is that a significance? Would you like to do a physiology check there? Is there a need, or I think we are just because the rest of the segment is so beautiful that is looking purely ocular response to it. I don't think there is probably any reason to address that. But what do you think? The mid portion of the LAD.
Just according to advice, I think for the physiology test, like the QFI, I think is okay.
Yes, I think let's do that. And if we can accomplish that in the next 4 minutes, we'll provide a good response. I must emphasize here that there are two real missions, purposes behind creating this behemoth program. I can tell you that although it's been a little more than 3 years, I probably have aged 10 years in this exercise. It's been very, very difficult. The challenges which come through regulation, through some legal aspects, technology, just the logistics of it is extremely difficult. It's been a great privilege and honor to work with so many exceptional experts. I think there is also a myocardial bridge there a little bit, so I don't think we need to be too concerned about that, but I think FFR will demonstrate, and I think it will be normal. So going back into it, it is my hope and vision. I'm going to use the next 3 minutes. I normally leave this moderation to the others, but since I've had the pleasure to come to China and share some thoughts with you, so my gratitude to many people, to Danny Trottier, to Jing Hao for all the Chinese centers. Believe me, your innovations, your grit and determination and support has made a tremendous difference. Just imagine, I was telling Dr. Shaolin Chen before the case that I try to watch anywhere between 18 to 20 hours of each case. I learn a lot. I think all of you would if you watch it. Danny Trottier, I know at Broadmed View, he probably sits through the entire 24 hours, and it's a tribute to his deep devotion that we are where we are. The experts who have guided me along, Dr. Samin Sharma, with whom I started CCC live cases. Believe me, in 2007, we were doing simultaneous Mandarin translation. So to all of you who have guided us along, are we doing the FFR?
Yeah, we are testing.
Okay. So if QFR, yeah. QFR. So let's get that answer. And Danny, if you are listening to me, and if Jing Hao is there, give us another 2 to 3 minutes more, and we'll provide you that answer. So it's been also all the incredible experts who have participated. I often tell people that in total creation of Medstream 360, I have logged on about 2,000 hours of speaking to world experts, asking them, if we started the concept of having no external excessive moderation, no time constraints. Many experts have guided me. The journey started by my asking experts. I remember conversations with David Muller, the Japanese physicians. So many of you have contributed, but in particular, the experts, some of them I would like to name Dr. Lee at Harbin, Dr. Shaolin Chen at Nanjing, Ajit Mulaseri and Shiv Kumar at Madras Medical Center, Dr. Praveen Chandra at Medanta Medicity. I'm not holding any sheet with me. These are people I can rattle off their contributions. Dr. Oli Bakar, who has been doing some amazing structural work at Copenhagen. Dr. Alfonso Jurado at La Paz University, absolute pillar of strength and academic excellence. Great procedural competence. His sessions are some of the most interactive. Moving from there on to Brazil with São Paulo, Dante Passaneses, Fausto, if you are hearing, and Ricardo is there with you, you do a fantastic job. Probably the best center we have. Buenos Aires, Dr. Oscar Mendes is a phenomenal operator. His cases are viewed religiously in Central and South America. The Montreal Heart Institute, in many ways, that is a model institution with 6 top-class operators who keep alternating to Mount Sinai with Samin Sharma and, of course, Dr. Prakash Krishnan, Dr. Vishal Kapoor and their team, and our new center at Winnipeg with Dr. Amir Ravendi, and closing it off with Dr. Saibal Kaur. Okay, we are, should we make a decision here? I think we need to move to the next site. I would like,
Exactly.
okay, let's do that.
Okay. So how about curve still ongoing?
So we'll give you a final answer on that.
Okay. Because we need to download this,
Sure.
the huge data.
Sure.
The view. Yeah.
How long do you think it would take?
I think leave it alone is better.
Yeah. I think that is a very good decision. We are very happy with the result.
Only minor plug burden in this.
Yeah. We're very happy. I think you're absolutely right. Even IVUS demonstrated there isn't a significant plaque there.
Yeah, I think so.
Excellent result with angiography. I want to thank you for your excellent case, as well as for all the previous ones you have done. And it is my hope and expectation that MedStream 360 will contribute to improving interventional cardiology and patient outcomes in China. Thank you so much for having me
here.
Thank
you, Professor. We're very happy to work with you. Thank you.
Thank you.